My name's Scott Freed. I'm an orthopedic surgeon with a specialty in hand and upper extremity problems and fellowship training in the same. I'm here to talk to you today about a new device that came as a result of an injury I actually had a number of years ago. This device is used to treat shoulder and arm problems for immobilization, and has changed the way we think about the use of shoulder immobilizers and upper extremity immobilization devices. To give you a little background, you may have heard the old adage, life changes in a minute. Well, mine did. I was on a ski vacation a few years ago, and for some reason decided to try snowboarding. At the end of the day, on the last run, I came down and caught the tip of the board and came down on my right shoulder. Came down pretty hard, and as I hit the ground, being an orthopedic surgeon, I realized I had torn my acromioclavicular and coraclavicular ligaments in my shoulder. As I lay on the ground, I must have hit my head a little hard because I thought maybe something good will come of this. Well, my son helped me off the slope, and after I got to the lodge, the emergency medical service people came, and they placed me in a device that they thought would hold me for the next 5 days in the blizzard that had just started. The device was what I'm going to show you right now. This is the type of device I was unfortunately placed in. I was quite uncomfortable, really not able to function. As I said, we were in a blizzard. There was no place to go. I was stuck for 5 days with 4 other families in a house and basically had to figure out a way to survive and also drive home. I couldn't live in this. My shoulder hurt. My neck began to hurt, and I had pain in my neck and down the arm. It was definitely not a device I was going to stay in for the next 4 to 6 weeks. I had to do something. Within hours, I realized I couldn't live like this any longer. I removed the other device because I just wasn't going to stay in it. I searched my room and my suitcase to look for something I could use to strap myself in. First, I went to my ski pants. I realized I wasn't going to be using these anymore, and I cut the straps off the ski pants and tossed them aside with my good arm. I then found a fanny pack and began trying to take the straps from the ski pants and tie them to the fanny pack in some way. I then placed the fanny pack on with a little help and placed my arm through one of the straps and looped the rest of my arm through the other strap. I felt instant relief at my shoulder. My neck didn't bother me anymore because there were no more neck straps. I realized that this, at least, was something that was livable, but gave me stability and protection for my shoulder and arm. The little bit of elasticity in the straps actually was good because it let me have a little movement, but yet kept my shoulder and upper arm immobilized. I realized at that point that this device met the 4 C's, the criteria we have at Doctor in the House for a clinically effective device. It had comfort, convenience, compliance, and clinical effectiveness. I was comfortable in it. It was convenient to use and put on. I was able to comply with it, use it for clinical hours, use it for activities, and still not have discomfort. And it was clinically effective. It immobilized the shoulder and arm, although it did not look like a stocky, large device. It worked. It worked better than anything else. I drove home in the blizzard for 12 hours with the device on. The system was born. I couldn't live in a regular abduction pillow such as Lisa has. Here, it was just too cumbersome and too awkward for me, and the type devices that were on the market were not livable. Getting in and out of a door, in and out of exam rooms, and sleeping was just too uncomfortable for me. So this evolved into the abduction pillow piece to the Ergo system, and Laura has on the now current system, you see. So we can use an upper arm strap if we want. We can utilize the forearm strap and or the wrist strap if we want. So for instance, if we have a patient immobilized here, we can keep them in nice and close to their body. If we utilize limited abduction, we can use the limited abduction pillow and place them in partial abduction, or utilize the full airplane abduction according to the intermittent immobilization protocol you use. Because remember, 30 minutes a day of abduction is all it takes to keep the shoulder from getting frozen. So if you don't need a patient immobilized in full abduction, you can have them spend most of their day in this kind of comfort and progressively free their wrist, progressively free the upper arm, and then the patient may only use the forearm strap for some time. They can perform some activities, but still maintain immobilization. Intermittently in the evening, they put in the abduction pillow, either the small pillow piece, or if there is great need, just stick it right back on the large abduction pillow, so you get more abduction, almost 90 degrees, or 90 degrees if you prefer. So what happens here is you have a device that continues to evolve with the patient's healing, but also gives them ultimate stability initially. When you have this pillow on and the initial rigid device, that arm is not going anywhere, and you can add the upper arm strap as well. The device you see before you today is a product of my story. We are hopeful that it brings you the same relief, comfort, and healing that it brought to me and my patients. Thank you for taking the time to listen.